Hello, good morning. Um, I thank you first for coming to our stand. Here I'm Ramon Luengo-Fernandez, Associate Professor at the Health Economics Research Centre in the University of Oxford. And I'll be presenting the project that was funded by the Stroke Alliance for Europe, assessing at what cost and assessing the economic impact of stroke. So stroke impacts people in all areas of daily living, speech, swallowing, walking, taking care of themselves. Therefore, it impacts survivors' health-related quality of life, as they are more likely to become disabled. Stroke survivors then have an increased use of healthcare and social care resource use. And stroke is widely acknowledged to be the major source of disability and health need. However, stroke is not a homogeneous condition. It varies or it ranges from small transient events that leave no lasting impact to large severe strokes affecting large areas of the brain, increasing the risk of disability and mortality. So why do we need a cost of stroke study? We need to know the size of the problem. In economics terms, we would use cost of illness study to assess which are the areas of the highest burden, and therefore for the areas of highest burden, we would invest in research and care so as to try and bring that burden down. We also need where the size of the problem is the biggest. So in which country region does stroke impact the most, which might then generate that we create more policies in those areas or regions. We also need to know the components of the problem. So for example, what makes stroke a costly condition? Is it because patients will need to more likely to have use of nursing homes, or is it because the acute care is so expensive because patients spend a long time in hospital? It also helps us inform decisions about investments. So for example, is a new treatment good value for money? Is the effectiveness of the treatment outweighed by the costs of that treatment? Therefore, it allows us to judge on cost effectiveness. So in our study, we looked at different costs of healthcare and of costs in total. So the first costs we looked at were the cost of healthcare. So visits to local doctors and nurses, emergency visits, hospital admissions, visits to hospital doctors once patients are discharged, and pharmaceutical care to either prevent or treat stroke. So the next cost we looked at, the cost of social care. Social care includes a big array of resources, including nursing care home and residential care home, where patients are institutionalized so that their needs can be better catered for, or because there's nobody in the community that can care for them adequately. There are many other examples of social care, such as Meals on Wheels, adaptations to people's homes, etc. But due to a lack of data throughout all 32 countries under study, we only looked at nursing and residential care homes. Then there's the cost of informal or unpaid care. Or these is a cost where no money changes hands, so nobody's get paid to care for a stroke patient. It still has an opportunity cost. And this is the time that family, relatives, friends, neighbors, etc. spend providing unpaid care for stroke survivors. Then again, a cost that doesn't change money, but it is an opportunity cost, the cost of productivity. And these could be because I have absent from work due to temporary or permanent incapacity or disability. So, for example, a stroke patient that have a stroke might need a week or two while they recover from their stroke. In those cases where the stroke is extremely severe and disabling, patients might not be able to return to work anymore. And then, unfortunately, there's the absence from work due to premature mortality, where people with stroke die and therefore die in their working age, so they will not be able to return to work. So let's look now at the work package 1 of our study. So in the work package 1, we looked at what are the costs of stroke in 2017. So we assessed cost of stroke in 2017 across 32 European countries. They included all European Union countries, including Iceland, Israel, Norway, Switzerland, and now that the UK is not part of the EU, the United Kingdom. So our brief summary of our methodology, we estimated costs for only 1 year, so annual costs for 2017. All costs were reported in euros, with 1 billion euros equivalent to 1,000 million euro. We obtain information from a large number of sources, ranging from international statistics like the Eurostat, OECD, or the World Health Organization, national sources such as country reports, report from ministries, or report from statistical institutes or data contained in National Statistical Institutes databases. We then looked at published studies, and we also made extensive use of large individual patient level data European surveys, and prominent amongst them was the Survey of Health, Aging and Retirement in Europe, SHARE. To take into account that prices in different European countries will not be the same, i.e. a cup of coffee doesn't cost the same in London as it will do, say, in Zagreb. We adjusted cost for price differentials so that when we compare cost in different countries, these kinds of living conditions or prices are adjusted for. We have published the results from this work package in a European Stroke Journal paper published in 2020, and it is free for access to anyone as it is an open access publication. So first of all, we using data from the global burden of disease, we estimated that there's approximately 9 million people living with stroke in Europe. Of course, countries with the highest populations will have the highest number of people living with stroke, and those like Malta or Iceland will have the lowest levels of people living with stroke. We also estimated that there were around 1.5 million new strokes every year, and that around 400,000 Europeans die every year as a primary cause, with the primary cause of death being stroke. Our headline results were that stroke cost Europe 60 billion pounds in 2017, but as you can see from this graph, costs were distributed more or less evenly across all areas of society. 27 billion euros of costs were in healthcare, the majority of that cost being in inpatient care. 16 billion of that cost was in informal care, i.e. the cost of the time of work or leisure foregone by carers. Social care cost 5 billion euros. And the remaining area was for premature mortality or inability to work. So here we also present what the costs are for every individual country in the analysis. And if we just look at the last column on the right, we can see the total cost and also the percentage of those costs that would be part of GDP. So we can see, for example, that in Luxembourg, stroke has the lowest impact in terms of the nation's economy, with only 0.14% of GDP lost due to a stroke, whereas in Germany, 0.54% of GDP is lost due to stroke. So dividing these costs in each country by the country's population, we get the health and social care costs per citizen in that country. As you can see, one of the main determinants of a country spending more money in stroke is their wealth. So at the top of the graph, countries tend to be either from Eastern or Southern Europe, whereas at the bottom of the graph, you can see that the countries that spend more on stroke on a per capita level tend to be Northern European countries. What is common in all countries is that a hospital care is the biggest component of stroke care in all countries. So it is all very good and well to know the cost of stroke now, but policymakers have to plan resources years and years in advance. So we also need to know what the future costs of stroke are. So one thing, although it is very difficult to project into the future, nobody would really deny that there are important demographic changes taking place over time in Europe. And the most prominent of this is the increase in the elderly population, matched also with decreases in the young and working age population. So if things continue as they are and forecasted, there'll be many more people reaching very old age in the future, with less and less of the working population able to either care or pay for those needs. So how do we need to know, how do these demographic changes affect the number of people having a stroke, the number of stroke survivors, and the cost of stroke? So in this work package, we evaluated the cost of stroke in 2030, 2035, and 2040. We assume that everything stays the same, except the age and gender structure of each country's population. So looking at data population projections from Eurostat, i.e. the statistical arm of the European Union, we found that for all countries in Europe, they will see a considerable increase in the population age over 65 years, ranging all the way from Bulgaria at around 15% increase in the over age 65 to Luxembourg, where more than a doubling in the age 65 and years and over population. And that is just in around 20 years from now. So then how does this translate from total numbers of more elderly people to an increase in people living with stroke? So we can see that again, for all countries, there is a considerable increase in the number of people who will be living with a stroke. So again, and you can see Bulgaria at around 10% increase in the total population with stroke, to Luxembourg with nearly a doubling in the number of people living with stroke in just 20 years' time. Apologies, my computer has stuck. Let's see if this works. Yes, it does. Sorry for that. So Again, those were just the percentage increases. So what are the total numbers? So for Europe, the number of people with stroke will go from 1.5 million people in 2017 to over 2 million stroke survivors. 2 million people having a new stroke, sorry. So suffering a stroke every year for the first time. And the people living with a stroke will be 12 million people in Europe. And as our headline grabbing slide, we can see how the costs will increase. They don't increase exponentially, but they increase linearly over time, no matter which subgroup of countries we look. So costs will increase from 60 million in Europe in 2017 to over 80 billion in 2040. And this is just looking at the projected stroke cost increases between 2017 and 2040. And again, you can see a considerable rise in stroke costs across all European countries. Again, with Luxembourg, the country forecasted to have greater increases in the elderly, having the greatest increases in stroke costs. And this again varies by country. So overall in Europe, it will be 85 billion costs, going from 23 billion in Germany to 53 million in Malta, the smallest country by population in Europe. So what will be the drivers of increased stroke costs? And you can see from this slide, first, if we look at the left-hand side, you will see that many countries will see a decrease in the cost of due to mortality and morbidity losses, i.e. Strokes happening in younger populations which are of working age, given that the population will be substantially more elderly, then therefore there'll be less people of working age having a stroke. That's why we see a decrease in those costs. But then looking at the true drivers, what will drive the costs of stroke up, the main driver from our analysis is informal care will be across all countries, will be the biggest driver. Again, this might be limited. Here we assumed that what happened in 2017 will happen in 2040, everything except the age and gender structure of the population. But one could hypothesize that if we have younger, a smaller pool of people of working age, we might also have a smaller pool of people being able to provide unpaid care. So we might see that these informal care costs are taken up by social care, which is much more expensive. So we have seen that stroke is places a burden to European economies, patients, and societies now, and that problem is not is only going to get worse. So what could we do now to try and reduce this burden? Even if we can't reduce it, try and halt this increase in the projected cost of stroke. So here in this work package, we evaluated treatment for stroke, and I'll go into them in a second. So we looked at the societal perspective, i.e. we looked at all costs we've been describing earlier over a 5-year time horizon. In terms of costs, we looked at healthcare resource use, informal care and productivity losses. And in terms of consequences, we looked at the survival, then quality adjusted life years, so i.e. quality life expectancy adjusted by quality of life, and also looking at the cost savings or additional cost each of these treatments might place in individual European countries and in Europe as a whole. So the first treatments we looked were anticoagulation therapy in people with atrial fibrillation in order to prevent strokes happening in the first place. The treatment we looked at was warfarin, and also we looked at new oral anticoagulants that have come into the into European markets in the last decade or so. So the intervention would be widespread use of warfarin or NOACs in people with atrial fibrillation. In the comparator, we looked at, although warfarin has been in the market for years and it has been shown to aggressively treat atrial fibrillation to prevent recurrent strokes. Previous evidence has shown that warfarin is substantially underused, even with people with no contraindications like a large risk of bleeding. So that could be partly because many of the people who have atrial fibrillation are significantly considerably old, and warfarin has quite nasty side effects and requires constant monitoring. So doctors might have seen warfarin as too invasive for older, frailer population. So our previous evidence found that large swathes of the population with a known atrial fibrillation were still being treated with aspirin only, and a small proportion, tending to be younger patients with AF, were treated with warfarin. So the main outcome of treating patients with anticoagulation therapy is to prevent stroke. And in our modeling exercise, our outcome would be quality adjusted life expectancy over 5 years. Another treatment we looked at was mechanical thrombectomy in order for people with severe ischemic stroke with large vessel occlusions, use mechanical thrombectomy as an acute treatment to remove the blood clots in a patient's vessels in the brain. The comparator would be intravenous thrombolysis for people under the age of 80 and non-thrombolytic treatment in people over the age of 80. The outcomes of mechanical thrombectomy are mortality, hopefully by removing the clots early, we can prevent mortality and also prevent disability. In our model, again, we looked at long-term outcomes in being quality adjusted life expectancy over 5 years. And finally, at the other end of the stroke pathway, we looked at rehabilitation after stroke. And by rehabilitation after stroke, we mention intensive community-based rehabilitation, not only rehab while the patient is still an inpatient in hospital. So our population would be stroke survivors discharged from hospital, i.e. more severe strokes, strokes that required admission into hospital in the first place, not say minor strokes that didn't need to be hospitalized but were treated in the community. Our comparator was current inpatient-based rehabilitation, which is not very intensive in most cases. Again, the outcome of rehabilitation would be to try and prevent disability or minimize disability. And in our model, we looked at quality adjusted life expectancy. So before I go into the results, what we did then was all these 3 interventions, we modeled them in terms of a Markov model, so trying to replicate what would happen to these patients if they received the intervention or not. So for warfarin, we found that around 6 million people with AF would be candidate for the intervention. Warfarin would generate a 7 billion cost savings for 32 countries, and it would be cost saving for all countries in Europe. In the graph, positive means cost savings and negatives means additional costs. So as you can see from the graph, the only component of cost which would be an additional cost would be major bleeding, because warfarin increases your risk of bleeding as compared to aspirin. And of course, if the intervention is more effective for all countries and also cost saving for all countries, then it turns that warfarin is cost effective also, not only for Europe as a whole, but for all countries in Europe. Now let's look at NOACs. Again, 6 million people with AF could benefit from routine therapy with new oral anticoagulants. However, because NOACs are quite expensive medications, throughout Europe, it would generate additional costs of 1.5 billion for all 32 European countries. However, they're more costly, but NOACs would be extremely more effective than warfarin or routine use of aspirin. So it would generate QALYs of 310,000 QALYs across Europe. As you can see from the graph, although NOACs generates cost savings as compared to our current treatment regimens, you can see that it would generate savings in terms of inpatient costs, i.e. preventing strokes, so less people are going into hospital. And we're also preventing people from having nursing care home use and need of informal care. However, for most countries, these costs are not outweighed by these savings are not outweighed by the cost of providing these medications, which is quite substantial. So NOACs would only be cost saving for 7 European countries. However, when we bring both cost and outcomes together, we found that using UK definitions of cost effectiveness, NOACs would be cost effective across Europe. However, if we use a country's GDP per capita as a measure of cost effectiveness, then NOACs might not be cost effective for 8 Eastern European countries. Then, looking at mechanical thrombectomy and the acute treatment of stroke, we found that nearly 300,000 eligible ischemic stroke cases would be eligible for mechanical thrombectomy across Europe. When looking at Europe as a whole, mechanical thrombectomy would generate cost savings of around 1.5 billion euros and would generate over 100,000 QALYs in that population. It would tend to be cost saving for all Western European countries, but not cost saving for Eastern Europe. So the costs we are preventing or the savings we're generating in terms of due to reduced disability, i.e. less people spending more time in hospital, less people spending time in a nursing care, a less need for informal care, would be outweighed by the significant cost of the intervention. However, this would not be the case for Eastern Europe. However, we found that for all countries, a mechanical thrombectomy would be good value for money, except maybe for Bulgaria, if we use Bulgaria's GDP per capita as a cost effectiveness threshold. Finally, for community rehabilitation, we found that around 900,000 stroke survivors around Europe would be good candidates for intensive community rehabilitation. This intense rehabilitation would generate $250 million cost savings for all 32 European countries, and would generate 62,000 QALYs for European countries. As you can see for the graph, for most countries, the savings generated by community rehabilitation outweigh the cost of providing that rehabilitation. And it would be cost saving for all countries except for countries, the most richest countries like Sweden or Finland in Europe. And that is because in Sweden and Finland, the cost of medical staff tend to be considerably higher than in other European countries. But what we found was that community rehabilitation would be cost effective for all countries in Europe. So this is the brief presentation of the study's results, and the main conclusions would be that stroke cost Europe 60 billion euros in 2017. These costs are projected to increase to 85 billion in just 20 years' time. We know there are proven effective treatments and interventions that cover the whole of the stroke pathway. However, we didn't know if these might be affordable or good value for money, especially for less wealthy countries in Europe. However, our study has shown that overall prevention with anticoagulants, treatment with mechanical thrombectomy for acute stroke, and community-based rehabilitation not only increase outcomes, they tend to generate cost savings and are generally good value for money for all European countries. And therefore, we would encourage countries to adopt these strategies, because not only will they be increasing the health of their populations, but they will also be using their money in a cost-effective way. Thanks a lot.